Today I'll be talking on newborn screening, which is the need of the hour. So, having a look at this clinical photograph, this was a 6-month-old child who presented to our endocrinology OP with, as you guessed it right, congenital hypothyroidism on the left. Now, no pats on the back, no prizes to us for making this diagnosis at 6 months. And although the treatment with Eltroxin has promoted a remarkable transformation in the picture on the right, we don't know what is the actual damage to the intellectual quotient of this baby. Which brings me to my topic on newborn screening, how to pick up these diseases in the newborn period. So what is the goal of newborn screening? The goal is to detect those disorders which do not have obvious symptoms during the neonatal period to prevent morbidity, mortality, and disability. And who should be offered newborn screening? All newborn babies, irrespective of gestation and birth weight or attendant illnesses, should be given an opportunity for newborn screening, regardless of whether they are born in a primary health center or in a high-end corporate hospital. Because all babies look normal at birth, and most diseases which are screened for, as I will be telling you later, have a window period where babies appear normal before the overt clinical picture of disease develops. So when we think about newborn screening, we go back to Wilson and Jungner, who first started the newborn screening program in the year 1968, and they have laid down 7 principles for us. And when we think about a disease which needs screening, it should be important and it should be common in the population that is being studied. It should have a suitable screening test. It should be difficult to recognize early because it has an asymptomatic period. There should be facilities for diagnosis and treatment. There should be an acceptable intervention that is available. The natural history of the disease should be known, and it should be cost effective to diagnose and treat. So when we think of newborn screening in India, we always think of about 40 different disorders with enzyme names which we have vaguely studied in biochemistry, high-end tests, and reference labs which are not placed in our part of the country, which we have to send to Mumbai or Delhi, doing fantastic enzymatic studies or molecular studies, and prescribing expensive diets. But when we think of newborn screening programs, there are a lot of simple things that we can do at home, at the bedside, to make a diagnosis of rather common conditions. So what is the basis of newborn screening? So the basis of a screening program varies from country to country. Obviously, countries like the United States and Europe screen for 40 to 50 disorders, but that is not economically feasible or ethically permissible in a resource-limited country like India. So core screening in India usually consists of a combination of tests depending upon disease prevalence. And in various parts of the country, this may include conditions like congenital hypothyroidism, congenital adrenal hyperplasia, G6PD deficiency, cystic fibrosis, sickle cell anemia, galactosemia, or biotinidase deficiency. If you look at the incidence of congenital hypothyroidism, it is 1 in 750 in our population. Congenital adrenal hyperplasia in South India, 1 in 2,500. But galactosemia and biotinidase deficiency, 1 in 60,000. The incidence of G6PD, surprisingly, in populations like Chandigarh is as high as 1 in 200, which makes it an eminently screenable disease in that part of the country. Similarly, we all know that Ooty, there is a high sickle cell anemia, there is a high sickle cell population, and therefore it makes sense to test patients or newborn babies in this part of the country for sickle cell. So that is the basic newborn screening that we were talking about. What is expanded newborn screening? Expanded newborn screening are those diseases that are diagnosed by PMS or MSMS, and these include rare disorders like aminoacidopathies, organic acidemias, and disorders of fatty acid oxidation. At present in our country, testing for this expanded newborn screening program is limited to those babies who are symptomatic, or when there is a history of developmental delay, or when there is a previous anomalous baby, multiple bad obstetric history, and or a patient who is presenting with acidemia or with uremia, and you think of a urea cycle disorder. So high uremia and high urea levels, and you think of a urea cycle disorder, these are the kind of babies who are thought of when we think about these disorders. And the disadvantages of this kind of screening for these kind of disorders, that the tests are very expensive. It costs minimum 5,000 to 6,000 rupees. And they need good reference labs, because sometimes we get lab results that are difficult to interpret. There are very few metabolic experts. And sometimes these patients, once they are given a diagnosis, it becomes a cumbersome thing to maintain an expensive diet for life. Currently, newborn screening programs in India are well run in 3 different parts of the country. One is Chandigarh, and here they are screening for 3 diseases, namely congenital hypothyroidism, adrenal hyperplasia, and G6PD deficiency, because the incidence there is high. Goa started off by screening for 40 disorders by a public-private partnership program, which ultimately failed. Subsequently, now they have restarted their newborn screening program by screening for these 6 disorders. And our own neighboring state, Kerala, where they are screening for congenital hypothyroidism, adrenal hyperplasia, G6PD, and galactosemia. So what about Tamil Nadu? As the focus on infectious diseases and resources is more in our part of the country, we are not screening for these kind of these kind of inheritable genetic and metabolic conditions. But when we want to bring the IMR to below 40, and there is only a certain amount of health that focus on nutrition and infectious diseases can do, we have to shift focus to genetic conditions and metabolic conditions to bring the IMR to a much lower rate. And I think that our state will also have to start a screening program for all babies across both public and private institutions for at least congenital hypothyroidism and hearing loss, and maybe include CAH, G6PD if there is a high incidence, and sickle cell in selected parts of the state. So let us go on to the first part of my topic, which is screening for congenital heart disease. So I would like to emphasize with the help of this scenario. This was a term child delivered normally, and it was the baby was sent home. On the 7th day of life, the parents noted that the patient had poor feeding and had a respiratory difficulty. So they went to their nearby doctor by day 10, and an echo was performed. And by the time the child came to us with an echo diagnosis of congenital heart disease, the baby was in shock. It had severe metabolic acidosis. There was Klebsiella pneumoniae sepsis. The patient was an acute renal failure and also had a conjugated hyperbilirubinemia. Echo diagnosis revealed a transposition of the great vessels with an intact septum and a small PDA. Unfortunately, because of the rather poor state in which this patient presented to us, the baby did not make it. So this is why we should start screening all babies delivered across all facilities in our state for congenital heart disease. And this involves a rather simple form of a rather simple screening method, namely pulse oximetry. So why should we screen for congenital heart disease? The incidence of congenital heart disease is 8 per 1,000 babies. This means that 8 out of the 8, 25% will have a critical heart defect, something like a left ventricular outflow tract obstruction or a duct-dependent lesion will be there. And routine clinical examination will miss at least 50%. And most of these babies will have a latent period or an asymptomatic period for the first 2 weeks until the duct closes and they become symptomatic. So what happens? What happens when we miss a diagnosis of congenital heart disease in these babies? Many of them die without even a diagnosis. And when we make a diagnosis and they come to us in a really compromised condition, they have 12 times more mortality in the first year of life. When they come to us, they come with organ damage involving the kidneys or the brain, which obviously cannot be good for their long-term neurodevelopmental outcome. And it also results in prolonged hospitalization and mortality. So screening for congenital heart disease was first started by Koppel in 2003. So he started by screening babies by doing just a postductal saturation and a single reading in 2 New York hospitals. Subsequently, this lady, Anne Devold Granelli from Sweden, was the person who actually improved and focused on this protocol of pulse oximetry to screen for congenital heart disease. She screened nearly 40,000 babies, and the results were published in the BMJ in the year 2008. So as we all know, preductal means the right upper limb. Postductal means all other limbs, because all other limbs receive mixed blood, both mixture of deoxygenated and oxygenated blood. So according to Andy Wall's protocol for screening for congenital heart disease, any saturation below 90% in any limb was immediately referred for an echo. Any saturation less than 95% of the limb, or a difference in saturation between two limbs of more than 3%, what they did was they screened again after 2 hours. And when the results were comparable to the first screening, then this patient was referred for an echo. You can see on the right the results of Andy Wall's study, which shows the results of physical examination alone, pulse oximetry, and a combination of examination and pulse oximetry. So when only physical examination was done, the sensitivity was only 60%, and the same was with pulse oximetry. On the other hand, when examination was combined with pulse oximetry, the sensitivity was 80%. What does this mean? If we have 5 babies with congenital heart disease, 4 of them you can pick up by doing a good clinical examination and a pulse oximetry. And the good thing about this protocol was the specificity was nearly 98%, which means that if you're screening 100 babies, only in about 1 or 2 babies, you will end up doing an unnecessary echo. So what are the diseases that are screenable with pulse oximetry? Pulse oximetry mainly focuses on screening the first 7 disorders in this list, namely transposition of great vessels, TAPVC, tricuspid and pulmonary atresia, truncus arteriosus, tetralogy of Fallot, and hypoplastic left heart syndrome. The other diseases that I have mentioned, namely the aortic arch interruption, critical aortic stenosis, single ventricle, DORV, and so on, are probably screenable by pulse oximetry. Cannot screen an aortic stenosis without a PDA, coag without a PDA, Epstein's without a shunt, or any left to right shunt with a pulse oximetry screening method. So the advantages of this method is that the time spent on the baby is less than 5%. You've just got to put the probe on the hand, on the right upper limb, right lower limb, record the reading, and that's it, you're done. Very high sensitivity, very high specificity, and a moderate degree of sensitivity. Very low false positive rates. That means no unnecessary echoes, no subjecting them for 2,000 rupees extra. And it is very cost effective because even the small nursing homes in the periphery will have pulse oximeters or multi-parameter monitors. So you only need to invest in a pediatric probe, which costs about 20 to 30,000 rupees, depending upon the company. And it does not increase the number of echo referrals. So if you're in a small peripheral facility, you need not be worried that you will have to send a huge number of babies for echocardiograms. And the question will always arise. I have already done a prenatal ultrasound. They have done a fetal echocardiogram. So I have ruled out congenital heart disease. Is it not true? But as we all know, prenatal ultrasounds are a very observer dependent one. And second thing, they only look at the 4-chamber view. So anything that is outside of the heart, like a TAPVC, will be missed by depending only on a prenatal ultrasound scan. So you can put the probe on any pulse, a capillary pulse, either in the palm of the hand or in the thumb, the great toe, or the dorsum of the foot, or the right brachial. And once you get a reading, you can record it. And the time spent is very minimal. So let us look at some case scenarios for following this protocol. The first child is a term baby, 3.2 kg, normal vaginal delivery, good Apgar scores, do a pulse oximetry after 24 hours. Both upper limb and lower limb show a saturation of 90%. So this clearly fulfills the first statement of Andy Wall's protocol, both limbs showing saturation of less than 90% or less. So this needs to straight away go for an echo. On the other hand, if you have a child where the second scenario, where the right upper limb shows a saturation of 95%, and the lower limb shows a saturation of 91%. Now the 95% is okay, but when you compare the upper and lower limb, there is a difference of 4% saturation. So in that situation, what do? We repeat the pulse oximetry after an hour or two. And then then afterwards, when we have a relook at the baby, we find that the upper limb saturation starts to drop a bit. Saturation is 94, and lower limb saturation is dropped further to 89. And the difference in between the two limbs has widened further. So this clearly indicates that this child needs to go for an echo for further evaluation. So when we think about lesions, the two important things that we have to bear in mind is one is TAPVC and truncus. In TAPVC and truncus, what happens is there is mixing of oxygenated and deoxygenated blood before the origin of the duct from the aorta. So in those situations, all four limbs will show low sats, and you will not have a difference in saturation between the upper limb and the lower limb. On the other hand, in a condition like TTGA with the duct, we will have a difference in saturation between the upper and lower limb, and this will help you to pick up, but lower limb sats will be higher. This is because that child will have reverse differential cyanosis. So this was a child who was born in our hospital, baby of Saranya, and this was picked by routine pulse oximetry at 24 hours. We found that the saturation was varying between 74-75% in all four limbs. Chest X-ray was classical of bilateral ground glassing, suggestive of intradiaphragmatic TAPVC. Echo confirmed the same. The child underwent surgery in our hospital, and this was the photograph of the child on follow-up at 2 years of age. It's very gratifying to note that a simple test for newborn screening can make such an enormous difference in the life of this baby. These are all babies who have undergone similar treatment in our hospital, either referred from an outside facility after newborn screening or picked up in our own facility with various complex anomalies like TGA, supracardiac TAPVC, and intracardiac TAPVC, all undergone intracardiac repair and doing well. So the next part of my talk will be focusing on another inexpensive, easily available, and very gratifying test for newborn screening, and that is hearing screening. So why is hearing screening important? Just like Wilson and Jungner postulated in 1968, there is a clear period where you can intervene and make an enormous difference in the life of the babies who are born with hearing loss. When you pick them up before 3 months, the intervention facilitates not only language and communication, but they also perform academically, and it promotes self-esteem in these children. You can see from this graph, vocabulary development in infants. As we all know, normal babies without hearing loss perform very well. But on the right-hand side, the shaded area, you can see babies who have hearing loss at 24 months, they speak less than 30 or 20 words. On the other hand, their peers will be speaking about 350 or 400 words. So clearly, hearing loss impairs vocabulary development. And there are lots of studies to justify this. Early language outcomes of infants with permanent hearing loss suggest that if the hearing loss is identified below 3 months of age, they had stronger language development. On the other hand, if hearing loss was identified later, then they had poorer academic and language development. So there are a lot of misconceptions in the general population and amongst us regarding hearing loss in kids. And one of that is that parents usually pick up the problems and parents will communicate problems to us. But a lot of studies have shown that if the babies have profound hearing loss, the average time at which these babies are picked up is 2 to 3 years. On the other hand, if they have only mild hearing loss, then they were not identified until they went to school at 4 to 5 years. And there are even studies in West Bengal that have shown that patients with mild hearing loss were picked up only at 9.4 years, a median of 9.4 years, which is really very late for any form of intervention or therapy. And we all have a high risk list. We know that babies who have been in NICU or who have had hyperbilirubinemia or meningitis needed to be screened. But using only a high risk list to screen newborn babies for hearing loss will miss 50% of babies with hearing loss. And hearing loss is as common as congenital heart disease. The incidence is between 2 to 4 per 1,000 live births, and it is one of the most common congenital anomalies. The other misconception is once you pick up a hearing loss, what do? Do you have the kind of access to interventions? It has been clearly shown that hearing aids can be fitted in newborn babies as early as 1 month of age and can make a huge impact on their vocabulary development. So this is the consensus statement on newborn screening by IAP in the year 2017. And this was born out of the Cochin experience where Dr. Abraham K. Paul, he conducted a successful screening program in Cochin where more than 1 lakh babies were screened for hearing loss, and they picked up about 200 babies with permanent hearing loss and intervened, created a significant difference. Subsequently, the IAP has come out with this statement, and according to this statement, all babies at birth should receive newborn screening in the form of an OAE test. If it fails, it should be repeated at 1 month or six weeks at the latest. If it fails again, then ABR audiometry should be conducted and they should be fully evaluated and intervention should be offered. So this is the IAP protocol, OAE at birth. If you fail the OAE at birth, then OAE at 4 weeks or latest by 6 weeks when they come for their regular immunization. And if that is also failed, then you go on for the definitive test and appropriate intervention. So this is just a list of risk factors for hearing loss. We all know that any admission to NICU, low birth weight babies have a significant incidence of hearing loss. Babies with craniofacial abnormalities, congenital infections, meningitis, hyperbilirubinemia, family history of hearing loss, and parental concern are all risk factors. But 50% of all babies with hearing loss will have no risk factor. So there are two tests, the OAE test and the ABR test. This is our nursing assistant, Saranya, performing the OAE test on our babies. So this is a very cheap, inexpensive test, and it is very simple to do. Get the baby to sleep, put the probe in the ear. The machine emits a series of clicks. These are received by the cochlea. The cochlea responds. The response of the cochlea is recorded in the machine, and you can take a neat printout of the test as it is given below on the slide and attach it to the baby's records. So OAE screening screens from the external ear up to the cochlea. It is a very fast test, and the only problem with this test is there is a high false positivity rate. That is 20% will have a negative test or a failed test because it is easily affected by amniotic fluid or debris in the external ear and also in the middle ear. So you have to explain to the parents very clearly that failing the test at birth is a normal thing and they need to have a repeat OAE screening at 4 weeks. And because it detects only the integrity of the cochlea, it is unable to detect the sensory neural hearing loss that affects other parts of the auditory pathway up to the brainstem. So first screening is before discharge, second at 4 weeks. A clear plan for follow-up is communicated to parents. And you have to communicate to them that fail implies possible damage. It doesn't mean that the child has hearing loss, but we have to do further evaluation. So once a child fails 2 OAE tests, then it has to go for a definitive test, namely the auditory brainstem response. For high-risk groups like your babies who are in NICU, low birth weight babies, hyperbilirubinemia, etc., you straight away do the ABR test. And when you have very small babies like a 28-weeker, then you can do the ABR test when they come up to 34 weeks post-gestational age. So this is your ABR test, and as you can see, the OAE test does not identify problems with the auditory nerve or the brainstem, whereas the ABR test identifies problems with the entire pathway. The auditory brainstem response, here 3 surface electrodes are placed on the forehead, at the nape of the neck and the mastoid. The probe is placed in the ear. It takes longer, it is expensive, it costs about 2,000 rupees. And it is the primary modality of screening for high-risk neonates. It has very low false positivity rates. Unlike the OAE test, which has a very high false positivity rate, about 20%, here it is only very low. It is very low, it is about 4% only. Therefore, this reduces unnecessary audiology referrals. So when your patient fails ABR also, then the patient has to be sent to a comprehensive auditory evaluation, followed by speech therapy, possibility of hearing implant aids and cochlear implant. So this is the 1, 3, and 6-month rule, which is very important in sustaining the hearing program. All neonates should be screened before 1 month of age. The initial screening test can be repeated before 1 month. After 2 attempts, the baby has to have an ABR test. Those who fail all screening tests, including the ABR, the testing process should be completed before 3 months, and they should have a comprehensive auditory evaluation, and appropriate therapy should be initiated in these babies before 6 months to have a good impact on their vocabulary development. What are the problems with our screening methods? It will not pick up late onset hearing loss, and it will not pick up also progressive hearing loss. Some of the neonates in your screening program may drop out after initial screening, and you may miss them. You may miss hearing loss in these babies. Sometimes we may have facility to do OAE test, but we may not have the facility to do an ABR. And sometimes we may be able to do ABR also, but there may be a problem in getting speech therapists or audiologists to intervene in our babies. So these are the problems with hearing screening programs, and we should try to overcome these. Finally, the last part of my talk will be concentrating on congenital endocrine issues, mainly congenital hypothyroidism, which is the need of the day. So the first case scenario is a baby who was seen in our hospital at the endocrinology OP. This was a term child who had a cord blood TSH of 55. As we all know, the cutoff for cord blood TSH is 20. So this child was evaluated with a full thyroid profile on day 7. The results showed that the T4 and the free T4 were also low, and the TSH still remained persistently high. So what do we do at this point? At this point of time, we can either refer this patient to an endocrinologist, or we can do 2 modes of imaging, thyroid ultrasound scan, thyroid scintigraphy to pick up the diagnosis. But what is more important is that treatment should be initiated without any delay. So this child had a thyroid scintigraphy. And what it showed was there was complete absence of thyroid gland. So the picture on the left shows the normal thyroid scan, and the picture on the right shows complete absence of the thyroid gland in the neck. This patient was started on L-Droxin 10 to 15 mics per kg per day and was followed up in our OPD. So coming to congenital hypothyroidism, the incidence is as high as 1 in 750. And as with all other disorders that we are screening for, only 5% are symptomatic at birth. The important thing and the most gratifying thing is that when you start treatment before 2 weeks, these babies can have near normal outcomes. But on the other hand, if there is a delay in diagnosis, it can result in very poor IQ. The test for diagnosis is very cheap and is easily available in most centers. And the treatment is also inexpensive. So when you look at the tabular column on the right, what we can see is that when the diagnosis is made before 3 months, the mean IQ is as high as 90. On the other hand, when the diagnosis is made after 6 months, the mean IQ drops to 50. This clearly shows us why we need to intervene early and why we need to have a good running screening program. So how do we base our screening program on? When do we do the thyroid screening program? So this depends whether we do it by cord TSH or at birth, or whether we do it at 48 to 72 hours by doing a venous blood or a heel prick sample. Depends on thyroid physiology as detailed here. So TSH surges in the first 30 minutes of life, and this surge is in response to exposure to the outside environment or to the stress of labor. Subsequently, it drops to normal levels within 48 to 72 hours. So either you can do the thyroid screening from cord blood or after 48 to 72 hours when TSH levels have normalized. On the other hand, if you try and do the TSH level before 48 hours, the incidence of false positivity in your screening program will be very high. So what are the advantages of either mode of testing? Cord blood TSH is easily obtained. It can be processed at a local lab. Even a trained nurse can take the sample. It facilitates early discharge of mother, especially in these days when most mothers are getting discharged within 24 hours. but it cannot, of course, include screening for other disorders if your screening program is designed to include them. On the other hand, when you do a TSH level after 48 to 72 hours, you need to train the sample, train the staff to obtain the sample properly and to affix it into the filter paper properly. And these samples usually go to reference labs which are far away from the hospital facility. It can include screening for other disorders. How to collect cord blood. So cord blood is collected from the placental end of the cord after it is clamped. The cord is first cleaned and it is wiped clean of metal, blood and debris. And it is cut between the clamp and the placenta, and blood can be either allowed to drip into the container, or you can use a syringe to enter the umbilical vein, which is easily visible on the surface of the cord, and aspirate blood and test it. Filter paper method is a little bit more tedious, and here the nurses need to be trained first of all to obtain the sample exactly on the medial and lateral side of the heel. The first drop of blood should be wiped away, and the blood should be squeezed, and these spots should be filled up accurately. On the right hand side, you can see a lot of samples, lot of filter paper samples which have not been done accurately, and therefore, these samples keep bouncing to and fro the reference labs, because if you send a sample, they find that it's not sufficient, as in the first category, or you might not have dried the specimen properly, it is a wet specimen, or it is supersaturated specimen. All of these will skew the results, and then you may not be able to run your program very successfully unless you have educated the nurses as to how to take the samples properly and how to put the samples on the filter paper properly. The other thing is that you should not use cord blood in a filter paper method, because cord blood usually contains a lot of debris and the blood will be contaminated. So as we all know, the cutoff for TSH by either method is 20. And when the baby has a high TSH level, we repeat the complete thyroid profile within 2 weeks. And if the TSH is still high and the free T4 and T4 are low, then we initiate treatment. If on the other hand, your the cord blood sample has not been taken, but the mother needs to be discharged within 24 to 48 hours, and you know that the parents are not compliant, they will not come back for further tests, do the TSH anyway and keep a higher cutoff. Because the most important thing is that no child should be discharged from the hospital without getting the thyroid screening done. So screening for all neonates, whether term, SGA or low birth weight or preterm sick, should be done before they are discharged from hospital. And for sick neonates admitted to the NICU, the screening should be done before discharge or within the first 7 days of life. If you have transfused the child before taking the sample, then maybe you can repeat the screening after 2 weeks, but no neonate should be discharged without getting the sample done. So let us look at the second scenario. This is a child whose cord blood TSH was only 10, which is well below our cutoff, and therefore this child was discharged home. The child was clinically well, there was no goiter. And during the first immunization, this child was noted to have slightly dry skin and passage of stools on alternate days. And subsequently, was noted to have further delay in milestones. So the important thing to note is that the screening program can miss 2 to 5% of all babies with congenital hypothyroidism. So initial screening, even if it is normal, the baby should be followed up clinically. And if you still suspect hypothyroidism, repeat a full spectrum of the thyroid function test, because some of these babies may have a slowly evolving hypothyroidism. And for example, this baby had a lingual thyroid. This was an ectopic goiter which was functioning okay for the first few months, but subsequently failed. Therefore, our initial tests were okay, but subsequent tests showed hypothyroidism. This is an ectopic goiter presenting rather late in a 12-year-old girl. Let us come to the third case scenario. This is another baby who's had a TSH level of 27. As we know, more than 20 is our cutoff. So this child was called back for a full thyroid profile on day 7. And the TSH was still high. but the free T4 and T4 were normal in this baby. What do you do in this case? If the family is compliant, then we can call them back for weekly testing, wait and watch, see if the thyroid functions, see if the free T4 and T4 levels drop. If, on the other hand, family is non-compliant, the best course of action would be to start thyroxine tablets and then wait for 3 years until the patient has completed myelination, and then stop thyroxine and re-evaluate whether it is a transient hypothyroidism or whether it is a permanent hypothyroidism. Very few babies present like this with a neonatal goiter, and when the diagnosis is a neonatal goiter, usually it is because of dysharmonogenesis or because of maternal exposure to antithyroid drugs, or it can be due to neonatal Graves' disease. Coming to the other endocrine problem that we need to screen for, this is a scenario that I'm sure everybody will have no problems diagnosing. This is a 10-day-old male child who presented with a 3-day history of poor feeding. And when he came to us, he was alert and crying, but he had a depressed anterior fontanelle, sunken eyes. His heart rate was only 60, he was bradycardic. His SATs were okay. His respiratory rate was 50 per minute. When we did his blood gas, it showed a potassium of 9.3 and a sodium of 112. So this child had congenital adrenal hyperplasia, as you have all diagnosed. And this was a male child, and there was some slight darkening of the external genitalia on clinical examination. So the incidence of congenital adrenal hyperplasia is been reported variously from 1 in 10,000 to 1 in 20,000 to 1 in 2,750 in South India. We all know that 95% is a 21 hydroxylase deficiency. If the child is a female child and presents with virilization of the external genitalia, it is easy to make a diagnosis. But the idea of screening is to detect the non-virilized males. These non-virilized males may present with an acute adrenal crisis. Some of them may not present with an adrenal shock, but they may present later with precocious puberty. So the idea of newborn screening in congenital adrenal hyperplasia is to prevent babies from presenting to your emergency department with shock or presenting to your endocrinology department with precocious puberty. Also, assigning a proper gender becomes very easy when you have a screening program going on. Otherwise, you will be mislabeling virilized females whom you have missed on clinical examination as males. So the picture on the left shows a pair of twins who are born in a hospital. They had virilization of the external genitalia, and workup showed they both had 3-beta hydroxysteroid dehydrogenase. The picture on the right shows a male child, 5-year-old, who presented with precocious puberty. As in congenital hypothyroidism, the cord blood is not helpful for screening in congenital adrenal hyperplasia also because the levels tend to be high. So we have to do a postnatal sample after 48 to 72 hours, and values are skewed in stressed babies, preterm or sick babies, and this has to be borne into account. And values are also different for low gestational age babies and low birth weight babies, and different cutoff values are available to be used for screening purposes. So once a baby has an abnormal 17 OHP level, then you either repeat the sample or do a short synactin test. If the mother has received antenatal steroids, then after 2 weeks, you can repeat the test because the steroids suppress the HPA axis and produces a false negative result. I just thought I'd just share a slide about G6PD deficiency because the incidence in some parts of our country is really very high. In Chandigarh, it has been reported to be 1 in 195, and this makes it the most common enzyme deficiency and genetic disorder in the whole of India. As we all know, it is X-linked recessive, and in newborn babies, they can present with very severe jaundice, but the anemia will be very mild. But on the other hand, when it presents in older kids, they will present with an acute hemolytic crisis. So they will need multiple transfusions, or they may go into acute renal failure and need dialysis. And the intervention, once we have screened these babies for G6PD deficiency and diagnosed G6PD deficiency, is very simple. Just give them the list on the right. That is the list of drugs to be and foods to be avoided, and send them home, and the job is done. So what are the components of a successful screening program? In this talk, I have not talked about screening for the expanded screening program disorders like amino acidopathies, organic acidemias, and fatty acid oxidation defects. Because I think that economically and ethically, it is not possible for us to do all those tests. So our screening program should include simple disorders, cheap tests, inexpensive tests, but for disorders that have a high incidence locally, easy to pick up, intervene early. So when we have a successful screening program in our hospital, we should have a good algorithm and good follow-up of the results. And you should have a procedure for repeating tests, and a positive test should be always confirmed, refer to appropriate therapy for appropriate intervention, and the screening process should be an ongoing process. And the stakeholders should also do regular stock taking, see where problems arise, see where loopholes are there, and try to plug the loopholes in the screening pathway. So this was a child who was seen by me about a week ago. This was baby of Sumati. On the 7th of November, the core TSH was 22.5, and in our hospital, we have a SMS alert. So the SMS alert was received by me, and that is seen on your right, on the lower end of the screen, which says that the neonatal TSH is 22.5. So this immediately alerts the consultant that something has to be done. So we repeated the thyroid profile on the 10th, which again showed that the TSH remained high at 30. The T4 was low and the free T4 was also low. So because we have the facility, we arranged for a thyroid scintigraphy, and basically it showed 2 foci of ectopic thyroid gland near the tongue. This child on the 3rd day of life was started on enteroxin, and a follow-up appointment has been made with the pediatric endocrinologist, Dr. Akila. So the reason for showing this cycle is that when we closely follow the results of these babies and start them on appropriate treatment, that is when our screening program becomes successful, because it is important to plug any loophole in the screening pathway. So as a pediatrician, what are the screening programs that I should offer? I personally feel that all neonates should be screened for congenital heart disease and hearing loss. And screening for congenital hypothyroidism should be universally offered. There are no excuses because the cost is less than 100 rupees. Whereas for other disorders like adrenal hyperplasia, G6PD deficiency, cystic fibrosis, sickle cell, galactosemia, etc., you can offer the screening test to the parents based on a one-to-one discussion if you have a clear pathway for follow-up of results and also a clear idea of what interventions are available. For screening of other disorders like amino acidopathies, etc., it can be done in sick neonates and high-risk population and only resource-rich settings. So in conclusion, universal screening for hypothyroidism is a need of the hour in both public and private institutions across the state. And all practicing pediatricians have a responsibility to screen for hearing disorders and congenital heart disease. As Dr. Ashwath mentioned, we also have a responsibility to screen all newborn babies for congenital anomalies, which we do anyway. When we screen them, we look for cleft lip, cleft palate, cataract, developmental dysplasia of the hip, spinal abnormalities, and so on. The screening for hypothyroidism, hearing disorders, and congenital heart disease should supplement our clinical examination. Local incidence and resources can determine screening of other disorders in the basic newborn screening program. And whenever you have sick neonates, history of developmental delay, or history suggestive of IEM, then you can screen for the more expanded screening program disorders like amino acidopathies, etc. The follow-up of results, stock taking, plugging loopholes, and directing the parents to an appropriate intervention is very important for a successful program. Thank you and happy Children's Day.
Thank you, Dr. Soumya, for that very comprehensive and very in focus discussion on approach to newborn screening. We were all benefited. Dr. Arivarsi has asked a simple take-home algorithm that you could suggest for practicing pediatricians to follow. Would you have a pre-prepared form or something that you could share with us, ma'am, or you could just tick off what you would like to all of us to do?
If First of all, I'd like to express my thanks to Dr. Akila for sharing her clinical material with me, and Dr. Vijay Kumar, who shared slides of his babies who have been operated. They all helped me with this talk. As far as our screening programs are concerned in our own hospital, we are doing a hearing screening program. We are screening for congenital heart disease, and we have a congenital thyroid screening program. Other than that, we are not screening for any of the other disorders as of now. And our algorithm for screening hearing disorders is as detailed, as the IUP. We do an OAE at birth, and we repeat the OAE at 2 weeks. And if the baby still fails OAE, then we get a BERA done before 3 months of age. And as far as our thyroid screening program, we do a CORD TSH based program. If our screening cutoff is more than 20, we repeat the thyroid profile at 72 hours. Immediately, we do a thyroid scintigraphy because it is available in our hospital and start Emtroxin. We also routinely screen all babies by pulse oximetry for congenital heart disease. And if their saturations are low, we refer them for an echocardiogram. We are not doing any of the other tests in our own hospital. I'll be happy if other people in this August group can share their own experience.
I think Dr. Arivarsi's question has been answered by Dr. Soumya. Ma'am, with your vast experience in neonatal services, could you also shed some light on how we should go about screening children for visual impairment, especially the micropreemies that we all specialize in?
All babies who are born in our hospitals who are term should anyway get their eyes checked. You should check their red reflex on both eyes and document it in your case sheet before discharge. That is a given. For premature babies, ROP screening is done, and the time for screening is either 4 weeks or 32 weeks corrected gestational age, whichever is earlier. And all babies who are less than 32 weeks, actually, although the Western criteria says 32 weeks, we actually follow a cutoff of 34 weeks. So any baby who is less than 34 weeks admitted to the NICU gets screened, and they are getting screened either at 4 weeks after birth or 32 weeks corrected gestational age, whichever is earlier.
Could everybody except the speaker please mute themselves? Thank you.
Screening is performed in our hospital by ophthalmologists from Aravind Eye Hospital. And for subsequent follow-up, they go to Aravind Eye Hospital because Aravind Eye Hospital has a red cam there. So most of these images are recorded there at Aravind Eye Hospital, and they also have the option of giving them laser treatment if necessary. When they come to screen the preemies in our own hospital, they bring a portable indirect ophthalmoscope, but they do not record the images. So for subsequent visits, they go to Aravind Eye Hospital for screening.
Thanks, ma'am. Since Dr. Akila is in the audience, I would like to ask Madam's expert opinion on whether the incidence of CAH would warrant us all to look for it, or do we have to have more data in hand before we incorporate universal CAH screening? Like we talk about hypothyroidism in a different plane, probably because it's more common and more easily amenable to treatment, but the consequences of an undiagnosed CAH are also equally devastating. Do we have data on hand on what is the incidence of CAH in South India? Should that be part of the screening as much as congenital hypothyroidism? Dr. Soumya or Dr. Akila, anybody can answer this.
I think both of us have had this discussion any number of times. I think we have knocked our heads together whether we needed to include CAH. Over the last 15 years, we've discussed it a time and again. I don't think it's the cost benefit ratio. If you look at it, I don't think we've actually benefited from doing CAH screening, because I get all my references from the other hospital which do CAH screening. Any number of times there's so much of mental trauma to the family with slightly altered 17-OHP results, and then we go ahead with Synactin again, because these babies are stressed babies. You have cortisol and 17-OHP, which are really difficult to interrupt. interpret because cortisol, we don't do LCMS in India except for one lab, and that too only recently. Everything else is done by other assays which actually have cross reactivity. So 17-OHP can show up as cortisol, you will have a near normal cortisol, and you will have 17-OHP which is very high due to other reasons, because if the baby is preterm, it's stressed, then the adrenal axis is activated and you get results. I don't think in all these 15 years when we've been talking about screening for CAH, I think there's only one baby we've missed so far, and we haven't missed one single baby in GKNM for CAH in spite of not having a CAH screening program. Though there is only one reference from a center which had multi-center experience, and they say the incidence is 1 in 2,750. I'm not very sure how good that is. Then you will have to remember 1 in 2,750 means it includes both boys and girls. Anyway, girls will show up because they have an altered external genitalia. So that is, you're actually getting one case for 5,500 cases you've screened for. And in that 5,500 cases you've screened for, you will actually evaluate by synaptin stimulation test, and that will cost about 10,000 rupees to do a full-blown synaptin stimulation test with the synaptin. Now it has come to India. Earlier we had to import it, and then we have to look at the 17-OHP, which is so fallacious. We've had real issues with that, and that's why we kept away from CAH screening, though all the centers talk about it in the world. Another point you have to remember is you're only picking up salt losing and helping salt losing CAH. You can still have non-salt loser CAH, which can manifest later, and you may not see them on a screening program. I've had one child which was picked up in another hospital. The initial 17-OHP was high, but the synaptin stimulation test was normal. But then at 2 years of age, this child showed up with CAH. So I don't know where we went and where we missed. So there are so much of confusions in interpreting 17-hydroxyprogesterone results. That's why me and Soumya, we've discussed, I think almost every 2 months we knock our heads together, because everybody else does, and we have an endocrine department and we don't do it. But we kept away from it purposely because so much of mental trauma. I've seen parents come pray that their child should not have, and then I'm also not very clear with the results. I start them on hydrocortisone because I'm also worried. Then I stop at 1 year and then reevaluate. So much of difficulty in that, and that's why we've kept away from CAH screening.
Thanks for that detailed deliberation, Dr. Akila. Dr. Soumya, can I disturb you once again to ask you, is there we have different cutoffs for congenital hypothyroidism on cord blood and taken at 48 hours and then subsequently. Do we have an ideal time to screen these babies for congenital heart disease? Because in a corporate hospital like ours, most deliveries are decided by parents. The time of discharge is also decided by parents. They are extremely anxious to get away before Saturday, Nallanal, Kettanal, all these sort of non-medical issues also keep kicking in. So is there a direct influence of the time of the congenital heart disease screening? Does the preductal, postductal value also vary with the anatomical closure of the physiological closure of the PDA? Is there some data to hand, or is it can be done at any time?
This study by Andy von Granelli from Sweden, what she said was, if you do the screening by pulse oximetry after 24 hours, the incidence of unnecessary echoes has come down to 0.17%. But if you do it before 24 hours, it is only 0.4%. I mean, so I think it's a difference between 1 or 2 echoes per 100 babies. So if your babies are going home before 24 hours, you might as well do the pulse oximetry and send them home. That is, the data shows that between screening before 24 hours and screening after 24 hours, there's only a difference of a few 0.3 or 0.4. I mean, which is really not much in numbers.
Okay. Dr. Arivarsi wants again to have your take home on the absolute minimum that a practicing pediatrician in the periphery should go home. She's reiterated that question. Probably she's not been answered. Could you answer that question again, Dr. Soumya? She wants to know the absolute minimum that a peripheral pediatrician has to screen for.
So the absolute minimum is the pulse oximetry, thyroid screening program, and the newborn screening program. The pulse oximetry, all peripheral facilities have pulse oximeter, so there will not be an investment. TSH levels cost less than 100 rupees to do. The thyroid, the hearing test costs about 300 in our hospital. The equipment costs about 3 lakhs, the OE equipment, but you will recover the costs of the equipment after screening about 1,000 babies.
It's heartening to note. Yeah, probably that's a very strong selling point. I think it should be nice if you could follow the Cochin model, where even private nursing homes who don't have the OE equipment, they have a tie-up with the traveling OE machine, which says all babies delivered in this hospital can come into a specified place on Mondays and Thursdays of each week. If we can do it for BCG, I'm sure we can do it for hearing screening. If Cochin can do it, a city of the magnitude of Coimbatore, such an emancipated or population, we should also be able to offer it even in nursing homes which are non-institutional. It's a pity we have still not started doing that in a bigger scale. Any inputs from, any comments from the other Vidwans, Dr. Venkatesh, Professor Srinivasan, Dr. Akila, do you want to add anything? Dr. Paniraman, Dr. Amal Raj? Any special comments, any comments apart from congratulating Dr. Soumya on a wonderful 1 hour of very engaging topic discussion?
Except for wonderful, nothing to comment.
Thanks, Ma. Thanks.
Raman has been putting his comments, and of course, I have been listening, and a wonderful job you are doing. So I know your father right from this thing, and we meet often. Recently, I met, and you are definitely doing a very good job, as good as your father. Congratulations.
Thank you, sir, for your blessings and wishes. Thank you.
I just add a point, the question in the chat.
The purpose of, hello, Soumya,
Sir, Solan, sir.
the purpose of this pulse is we have to sensitize all the primary, as Dr. Aswath said, primary care pediatrician to know about the screening. And I think you have mentioned about the false negative. The negative result does not rule out the major diseases, inborn error of metabolism, hemoglobin, all those things. But there is some false negative cases, as you have mentioned, is a prematurity, the timing, sepsis, all this can even cause the false negative result also. Now, what I routinely found is some of the mothers, they routinely ask for jaundice. Sir, jaundice screen paniyacha, jaundice patacha. Every, at least at the time of discharge, we should do this critical care heart disease. And as I got an OAE in my clinic and Billy check in my clinic. As Dr. Aswath said, I have to take this. Whoever wants it, I can do that and then give that, because this is more important. We have to sensitize all the pediatricians about the newborn screening. All the 5 we have mentioned about it. Wonderful presentation, Dr. Soumya.
As Dr. Ashwath mentioned, the hearing program in Cochin actually originates from the IAP branch, Cochin. And they have 3 screening machines and 3 volunteers. And if the hospital has a delivery rate of more than 200, they go 2 times a week to that hospital. If it is less, they go less. In that way, they have screened almost 1 lakh neonates over a period of nearly 12 years. And the gratifying thing that they found in Cochin was the number of referrals for audiology was less than 200, which means that their pickup rate, their follow-up rate, everything was very good. And the ABR test cost is 2,000. So only 200 babies out of a lakh needed an ABR test, and were subsequently, intervention was offered. So the way they planned it was, they trained people and they had 3 machines, and they kept going to different hospitals frequently based on the number of deliveries.
Yeah, that's very, very nice and very good initiative from IAP Cochin. Dr. Abraham Paul and Dr. Jason Unni had the foresight to go ahead and start this, and then Goa is able to. I think Kerala, Goa are all administratively small places. Therefore, they're able to do these things because they have the full support of the population. I think we should also get the ball rolling. IAP Coimbatore has the funds to even gift a OE equipment to CMC General Hospital. I'm sure Dr. Boomer and Neonatal Services could approach some NGO who can probably give them, because the number of babies who will be benefited by this simple intervention, it's really money well spent, I think. That is something that the CMC-GH Department of Pediatrics and Neonatology could look at. We have the cash, and we have lots of well-meaning individuals as part of their corporate social responsibility. Also, OA equipment can be procured and given at least to the smaller hospitals. That's something very useful, we think.
Can I
There are
make a
no more.
comment? Can I make a comment?
Sure, sir.
Sorry for interruption. Okay. So if Coimbatore cannot do it, no other districts in Tamil Nadu can do it, especially with stalwarts like I know all of you and your capabilities. So I'm sure it'll be a reality in another 1 year. Within 1 year, I expect it'll be a wonderful thing happening. So I'm very optimistic and I'm very sure it will be done. Okay, thank you.
Thank you. Thank you for your blessings, sir. There are no more questions.
Can
So
I
I
make
take
a
this
comment?
opportunity. Sorry. One second.
So this question on what is the cutoff for T4 and free T4 also had been raised. But I think that has to be lab specific, because the cutoffs given by Indian Society for Pediatric and Adolescent Endocrinology actually does not work in our own hospital for free T4. So we actually, the TSH is much more easier to measure and much more sensitive. So stick to your T4 and then have specific age related cutoffs for each of your age groups, including preterms, terms, and the amount of prematurity that the baby has. And remember to repeat thyroid screening 2 weeks after delivery for all children who are born preterm. That's extremely important to remember. Preterms have to have a repeat thyroid function test. So TSH is much more easier to have a cutoff, 20 for cord blood and more than 10 for any other method which you're measuring beyond 72 hours of life. And for between, as Soumya had mentioned very clearly in her presentation, between 48 and 72 is 34. But I think you either go with cord blood or repeat after 72. That's so much more easier to do.
If there are no further comments or questions, I think we can conclude the session. From on behalf of IAP TNSE branch, I thank Dr. Soumya for making the stupendous effort and collating so much data and taking the help of very generous colleagues in preparing a very, very sumptuous academic feast for all of us. And I wish you all a good night. Thank you once again, and congratulations, Dr. Soumya. Thank you.
so much. Thank you.
Good night, all of you.
Good night, sir.
Great day. Yeah.
Let's hope New Zealand beats Australia.
Doesn't matter. Whoever plays better on a
No,
particular
sir.
day.
If they have beaten India, they are good enough to beat Australia.
Yeah, because last time they were,
They were denied
of that.
the World Cup by
Last time they deprived of
Super
tie
over.
and then this thing. So you are correct.
Yes, sir. The Dharma has to be on their side.
Yeah, Ashwat cannot be wrong.
I hope so, sir. Good night.
Thank you, sir. Thank you.